Morning, everybody. It's 11:01. I think we can get cracking because I don't know if anybody's read the paper, but it's quite a long paper and very detailed. So I think we need to give Grace a few extra minutes to present. So welcome to the third session of our third webinar in our revamped webinar series after taking a long hiatus last year. As you know, the series is entitled Early Childhood Systems, Perspectives and Research, and it is a partnership between Ilifa Labantwana, RESEP at Stellenbosch University, and Data Drive 2030. Today's presentation is by Dr. Grace Leach. She's co-authored a super interesting paper with Prof Dieter von Fintel entitled Promoting Early Childhood Development Through Multidimensional Service Delivery in South Africa, a Municipal View. The paper was published in June 2024 and can be downloaded on our website, I think. A bit about Grace. Grace is a Post-Doctoral Fellow at the Department of Economics at Stellenbosch University. Her PhD looked at the economics of early childhood development and regional inequality in child health in South Africa. This paper draws from her PhD work, as far as I know. Her work looks at the environmental inputs to child health, including water, sanitation and hygiene, nutrition, and early learning program access. In previous work, Grace has focused on understanding inequality in South Africa, child hunger, and the mechanisms for protecting vulnerable and orphan children in South Africa. So that's what today is about. I'll give, I think Grace will present probably for 30 or 35 minutes, and then we'll go into questions. You can, as normal, you can put your questions in the chat or Q&A, and obviously also during the question time, we'll give people opportunities to ask the questions in person as opposed to just through the keyboards. So with that done, Grace, over to you. Thank you. Just firstly, thank you for putting together a really super interesting paper. It must have taken an enormous amount of work. And so we're very excited to hear you present. Over to you.
Thanks, Colin. Thanks also to Ilifa and Data Drive. It's really great to be here, to be part of the community and the sort of sector researching and looking at ECD. I'm excited to, share the work. So I am just gonna share my screen. Can everyone see my screen? Hopefully that's a yes. I'll take silence as a good thing.
Yes.
So, great. So this indeed is a paper, a chapter which formed part of my PhD. And I've titled it Promoting Early Childhood Development Through Multidimensional Service Delivery in South Africa, a Municipal View. And that's because I'm looking at a sub-national level of service delivery. I just wanted to flag that I'm formally also part of RESEP, so that is my sort of association, and I'm very glad to be here. So without further ado, the roadmap to this paper, sort of an introduction. It's part of my PhD, which focused on the economics of early childhood development. So I have taken a broader view on ECD and have looked at both the dynamics of early learning programs, as well as parental investment, as well as service delivery and spatial inequality in terms of how all those things come together, for a bit more of a helicopter view of the sector of ECD. And I personally, as a development economist, trying to understand inequality and poverty in South Africa, have kept coming back to early childhood as a really critical phase in life when the foundations are laid for development later in life, which enable a child to thrive and grow to their full potential. And given the importance of ECD both for individual children and for the health of a population in general, there's a strong policy emphasis on childhood interventions by many relevant role players, including many NGOs that I believe are represented on this call. Funding goes into ECD like crazy. Government is very excited at the moment around ECD policy and figuring out ECD. But the overarching view for me is really that healthy development in early childhood is a promising mechanism for the reduction of intergenerational poverty at its core. There are so many studies which show that children who thrive against the odds are more able to break out of these vicious cycles of poor health, lack of employment opportunities, lack of education. And I find that to be such a hope-inspiring and beautiful thing in the context of South Africa. But as we understand, as people who know about ECD, there are multiple and simultaneous economic, clinical, societal, public, private, all sorts of inputs are necessary for children to grow into healthy adults. You can talk to any parent who will know that a child needs many things to thrive. And while there is increasing consensus regarding the elements that children need, there is still a gap in understanding how these elements can be provided, especially in under-resourced areas in low and middle income countries. So this is really a paper that takes the research and the excellent science between the elements that children, around the elements that children need, and I'm trying to translate how the elements can successfully be provided together. Just an international context, in 2022, more than 140 million children in low and middle income countries have not been able to develop to their full potential. And there's growing evidence that this is really caused by increased environmental risk factors that these children face. So these environmental risk factors are hindering how elements that they need, such as food, water, etc., I'll go into that, how they can be provided. And this study kind of tries to latch into that literature. So what do I mean when I say all of the elements which children need to grow into healthy individuals? So we know that caregivers, be it parents or legal guardians, are primarily responsible for providing nurturing care to children. However, many of the aspects of nurturing care are very difficult to provide, especially at the same time where an environment doesn't support caregivers. In the paper, I go into a discussion of the complexity of providing, say, healthcare as well as nutritious food in a month where the child is sick and there is a limited budget. Or, for example, providing a safe place to play when there is no formal flooring and there are pathogens or dirt or maybe animals in the home, providing a safe place to play as well as eggs from the chicken. They're conflicting elements that children need, but they conflict with each other. So the environment that a child experiences on a daily basis is really a critical determining factor in shaping developmental outcomes. It's the environment where a child spends most of its time that is going to have the biggest impact on its development. And there are multiple factors which aid child development, and these have formally been conceptualized by UNICEF in a wonderful document, and they've been labeled this package of nurturing care. So what do I mean when I say nurturing care? So nurturing care is this framework that UNICEF has sort of labeled, and it has 5 key components, including good health, adequate nutrition, responsive caregiving, safety and security, and opportunities for early learning. Now, into each one of these 5 key components, you can imagine many subcomponents. For example, adequate nutrition includes age-appropriate nutrition, so exclusive breastfeeding for children below 6 months, soft food for children above that, enough protein, etc., enough calories, enough micronutrients, but also clean food, healthy food, engaging with the child while they're eating. There are many components to that adequate nutrition. Similarly, with opportunities for early learning, there are many different subcomponents to this main sort of headline. And I just also want to emphasize that the good health key component is made up of many different elements, including water, sanitation, and hygiene, access to healthcare, parents who respond to a child who might be chronically ill, etc. And really, when it comes down to it, the home, the neighborhood, and the local government capacity for service provision are all elements which create the context for nurturing care. So therefore, it's well understood that any attempt to improve child development must be multi-sectoral in nature and focus on the environment both inside and outside the home. And this word multi-sectoral is thrown around quite often in context of policy for early childhood development. And really, I think what it boils down to is making sure that multiple government sectors are involved, or multiple sectors of influence, such as sanitation, food systems, healthcare, ELPs, sort of policing and secure environments. They're all implicated in providing this context of care. So as well as there being 5 main key components, each of the factors which make up nurturing care also reinforce each other. And there's a tendency for the multiple inputs to be they reinforce each other and are concurrently complementary. And this is a fancy term for something that I think parents understand quite intuitively, that you can't substitute, say, good nutrition for sanitation, that the child needs both in order to grow and thrive. Similarly, it's absurd to say that you can substitute sleep, so the child doesn't need to sleep, and you can just give it extra breakfast and the child should be fine. The child needs both the breakfast and the sleep. And this boils down to the fact that they complement each other and build on each other to help the child develop fully. And this is seen in literature, in research, where we see that interventions which supplement the home, nutrition, or parenting, or all three, are more effective than those which only focus on, say, a package of early childhood care and education. So only intervening in the cognitive development of children or intervening in their opportunities for early learning is sure to help. But really, the interventions which supplement more elements of nurturing care are seen to be very beneficial. So additionally, just to add, this need for multidimensional intervention may be more critical in developing countries due to resource constraints, because children may not have adequate nutrition or health care readily available at home. So in this research, what I do is I translate this framework of nurturing care and I create an index of multidimensional service delivery for children in a developing country context. Obviously, I've chosen South Africa. And then in this paper, I go on to verify the index. So the approach is motivated by the consensus in the literature, which I've just spoken about, that children need multiple inputs at the same time for their healthy development. And it's further motivated by the growing call to reduce environmental risk factors for children in developing countries and provide children and parents in these places with services they need to promote healthy development. And this has really been a call that's been put out by a few Lancet special issues, understanding that children in developing countries are really being hindered from growing to their full potential and thriving, and that this is a dual burden of underdevelopment economically and underdevelopment in terms of human potential within those countries. So to conceptualize, what I do is I create a measure of nurturing care. So I apply something called multiple poverty index methodology, or multidimensional poverty index methodology rather, to South African data. And I translate the multiple inputs required for early childhood development into a single measure or index of service delivery for ECD. This allows the analyst to uncover where children are receiving the full package of concurrent services that they need, as envisioned in South African policy. Now, this policy document that I will reference is the National Integrated Early Childhood Development Policy of South Africa. It was published in 2015 and conceptualizes the multiple inputs that children need and that the South African government undertakes to provide to children in South Africa. So in doing this, I create and conceptualize a measure of public servicing at the municipal level, which should be seen as denoting the strength or failure of service provision for children and in support of early childhood development. Now, many of the elements of nurturing care, for example, access to sanitation or a flushing toilet in your home, can be seen as an overall sort of public service delivery item. But in this paper, I specifically focus on households with children. So how many households with children have access to this service? And while we can understand this measure as denoting service delivery in general, what I've tried to do is focus it specifically on the services that children need. And so I have a few missing gaps that maybe are a service delivery in general, but since that is not the focus, I'm focusing specifically on what children need. Great. So into how I have pipelined the National Integrated Early Childhood Development Policy into data. So I've taken the NIE CDP and I've looked at the specific services that the South African government undertakes to provide to all children, including healthcare and nutrition, social protection, parent support programs, opportunities for learning, national public early childhood development communications, housing, water, sanitation, refuse removal and energy sources, food security, and play facilities and sport. And what I've done is I've grouped them broadly into a service domain. So in the pink boxes here, you'll see different elements of the services that the government undertakes to provide to children taken from the NIE CDP. So you'll see these pink boxes over here. And I've grouped them into three main categories: healthcare service provision, public infrastructure service provision, and lastly, education service provision. And now the hunt for data began. So what I've done is collected multiple subdomains of specific service deliveries which help to conceptualize a healthcare service provision. And I've looked very specifically at how I could potentially measure the elements of the NIE CDP. So firstly, I looked at healthcare service provision. And at a municipal level, I have searched the internet, searched multiple data sources. I will show you the data I used in a second. In many cases, have gone to the appendices and addendums of government documents to look at the rates by municipality. I've scraped a few internet sites. And at the municipal level, I've been able to find the proportion, the prevalence of children who have been given their Road to Health booklet, who have full immunization, which is 14 doses of immunization by 24 months of age, minimum immunization, which is the 9 minimum doses of sort of vaccine shots by 1 year of age. Then I've looked at access to clinics, as well as food security for households with children. So those were elements that I thought measured healthcare service provision. Secondly, I looked at public infrastructure service provision, and I have measured the access that children have to sanitation, clean water, refuse removal, electricity, and safety. The safety one is quite interesting. I will zone in on it later. But the rationale behind including this safety service indicator was because I thought it was important for children to feel safe, to go outside and to play, in order for them to be able to engage in play facilities, sport, and culture. And there's a wonderful and growing literature which shows the importance of playtime, play spaces, and the learning that happens while children play. And being safe to go outside is, I think, critical in being able to play and grow. The last domain that I've looked at for service provision is opportunities for learning. And here was also an extensive data exercise in finding by municipality children's access to ELPs, ELP quality. So what, if children do have access to ELPs, what's a sort of average level of ELP quality within that municipality? And then I've also looked at whether or not a child has access to a teacher-resourced primary school. And this was suggested to me that I should look at a municipal level of teacher-resourced primary school access, because it motivates parents to send a child to grade R or to an ELP so that they are ready for school. If schools are not a sort of promising place to be, it was suggested to me that parents pay less attention to sort of an ELP environment, sending their child to an ELP. So what does this look like in reality? So what I've done is these are the subdomains that you will see over here. So each subdomain was first treated by itself. So I looked at what the South African government promises to do in terms of road to health cards. And the policy, according to the Department of Health in 2018, is that all children, 100% of children, are to be given a road to health booklet card from the Department of Health upon birth. So mothers are given this road to health booklet when they are discharged from the hospital after giving birth, or the clinic, or the MOU. And what I've tried to conceptualize is a cutoff below which a municipality can be said to be providing poor service in that subdomain. So if we take the road to health card, for example, we can see that my cutoff is that if less than 95% of all children have received a road to health booklet from the Department of Health, that municipality is said to have poor service delivery in the road to health card domain. Similarly, the cutoff for full immunization is less than 90% of children at 35 months, that are fully vaccinated. And then minimum immunization, which is also 90% of children at 35 months of age have received all 9 doses of the minimum required vaccines. And these policy guidelines were scrupulously, I researched each one and looked at the either international best practice in terms of UNICEF. So UNICEF stipulates that 90% of children being immunized is likely to provide herd immunization. The only two which were not, I haven't taken specifically from a policy guideline, are access to healthcare clinics and access to safety, or a safe place to play outside. So here my logic was that if a municipality has less than 1 clinic per 500 children under the age of 5, I did the math and argue that a child would have to wait for more than 6 hours at the clinic in order to be helped. And I thought that that was subjectively, you can argue with me on this, but I thought that that was too long for a child to have to wait at a clinic. And so if there is less than 1 clinic per 500 children under the age of 5, I have termed that as poor access to healthcare facilities. Similarly, with the safety indicator, what I did was I took some information from the community service or community census in 2016, which was a very large census of the population of South Africa. And the households were asked if they thought it was safe for their children to go outside during the day. And where less than 80% of children live in areas where they are safe to go outside during the day, I have said that this means that over 20% of children can't go outside during the day, and they are limited from having a safe place to play, and that this is a poor public service delivery in terms of safety. Now, I thought that it was important to also explain the quality of ELP's indicator, because I think some people on the call might either have written the paper which I quoted, or have a question. So I just want to double click on this, and then I'll go through the rest of the presentation and the results. So here, Key Chemistry and Wills in 2022, which is a paper that was it's also published by ELIFA. So they argue that if a ELP has met 75% of government regulations, that this ELP can be considered to be a high quality ELP. And we do this using a data set, which I'll show in a minute. And I have said that a municipality provides high quality ELP access to ELPs if 75% of ELPs meet 75% of government regulations. And these include all of the regulations that many people will be familiar with, which a ELP needs to meet in order to register with a DSD or the DBE. So here's just a list of my data sources and the year in which the snapshot of data was taken. And I just want to make the observation that the National Community Survey of 2016, the data is arguably a bit old by now, but many of these indicators are very slow moving. Economists call them they're indicators that move slowly. So access to sanitation or waste removal is unlikely to have changed drastically since then. Hopefully they will change soon. But so what does this look like? What I've done is I have gathered all my data and then gone and calculated if a municipality has service below the cutoff in each domain. And here I show a table with each domain and subdomain of the percentage of municipalities that have poor service provision. Therefore, they do not meet the cutoff. So just to highlight a few, that 71% of municipalities have poor service delivery and waste removal. Over half of municipalities do not give a road to health card booklet to 95% of children. Only 15% of municipalities have poor service provision in healthcare facility access, which I think is encouraging. But here is basically, we can see that there's a general and quite widespread failure to meet many of these service subdomains. What does this look like geographically? This is a map of South Africa. You can see cities, major metropoles are shown with the black dots, and the black outlines are the borders of former homelands. And each of these shaded areas is a different municipality in South Africa. And the color of the shading indicates for how many domains a municipality is failing in service provision. So here, where you can see light colors, sort of in the Northern Cape region here, we can see that this municipality is only failing in 1 or 2 subdomains. In these municipalities in KwaZulu-Natal, where we see very dark colors, we can see that the municipality is failing to provide service in 9, 10, or 11 subdomains, which is extremely worrying. I've also produced these maps by individual domains and by subdomains. One of the wonderful things about an MPI index is that it's you're able to sort of divide it by the subdomain. And here we can see that there's pretty good access to public services in many areas of the Cape and sort of the interior of the country. We can see that health services are sort of poor in sort of the center of the country around Gauteng. And we can see some definite hotspots where access to education services are very poor. And the point that I was trying to make with these subdomain maps, or these domain maps rather, is just that it's very useful for a government policy perspective to take these maps to the Department of Education, for example. And instead of criticizing, saying to them, look, we found real hotspots where improving the quality of ELPs or improving access to a teacher resource-sourced primary school is likely to be really effective in these areas. And it's more applicable in terms of policy guidance. So next, what I do is test the validity of the index. So I've got this index of service delivery, which measures the success or failure of service delivery for early childhood development in South Africa. But does it measure something? So I go on to relate the municipal level of services to child outcomes. So what I do is run multiple regression analyses with different models using Thrive by 5 data. And I'm sure many people on this call are familiar with the suite of ELOM tools and the data which DataDrive has made publicly available, called the Thrive by 5 data, which was taken in 2021. And this includes measures on child's health or their stunting, as well as their ELOM score. I don't really have time to go into stunting, but suffice it to say that it is when a child is too short for their age, and it is a general indication that the child is not receiving the inputs that they need to thrive. So in this validation exercise, I found no connection between municipal service delivery and health outcomes. And when I got these results, I had to take a break. I had a cup of tea, went on a walk. I was extremely confused. But I did find a strong connection between public service delivery and a child's ELOM score. So that is the children in ELPs in ELPs that are in municipalities with better public service infrastructure, they scored significantly higher in their ELOM assessments. So I have these two conflicting results. There's no connection between municipal services, any municipal services, and health outcomes, but there are strong connections between public services and ELOM score. So let's talk about those weird results and the importance of considering the sample selection in our data. So it's critical to remember that the Thrive by 5 data samples children who are 4 and 5 years old, or 50 to 59 months. If we look at the GHS, which is the General Household Survey, we can see that less than half of 4 to 5-year-olds attend an ELP. Just over half of 4 to 5-year-olds do not attend an ELP. So by definition, the Thrive by 5 data is talking about these children, the ones that attend an ELP because they've been tested at an ELP. So these children that attend an ELP have an average monthly household income that is 3 times more than households with eligible children not attending an ELP. That is, these children that attend an ELP or households where the parents have sent their child to an ELP are on average 3 times more wealthy. Additionally, the stunting prevalence in children who attend ELPs is half the national estimate of stunting prevalence. This means that the children who do not attend ELP are much more likely to be stunted. So what does this mean? It means that the level of municipal services, which is not significantly associated with stunting in children who attend ELPs, does not mean that the municipal level of services is not significantly associated to stunting in the population. Households who select into ELP attendance are more advantaged. The children from these households are less likely to be stunted, and the household environment is more likely to provide support in each of the important elements that are needed for children to reach their full potential. For this reason, it appears that nutritional status or stunting in the sample that is selecting into an ELP is insensitive to ELP quality, though this may not be the case in the broader population of children. So if by a miracle we had the ELOM score and the stunting of the population of South Africa, we may see much more results that are much more likely to be estimates of the true impacts of municipal service delivery. So more importantly, the point that I would like to make, the point that I would love for you to consider and take home, is that the children who are not attending an ELP are not reaping the potential benefits of cognitive stimulation in the ELP, and they are more likely to be influenced by municipal services alone relative to the children who attend an ELP, where they may have better access to healthcare or nurturing care by the practitioner, etc. So improving municipal and household environments is critical for these non-attendees. I would also like to argue that improving household and neighborhood and the local government capacity for service delivery is likely to really be very beneficial for the children who are attending ELPs. A child who attends an ELP is spending at maximum 4 hours, 5 hours a day, 5 days a week in an ELP. The rest of the time, the majority of their week, they're spending in an environment. So they're spending in an environment which is either serviced or it's not, or there's clean water or there's not. And this household environment is going to have a critical and determining impact on the child's development, and that getting this right is a critical element of understanding ECD as a whole in South Africa. So to conclude, in this research, I show that MPI methodology can successfully document the level of multidimensional service delivery for children in different regions of South Africa. This data-driven approach can quantify where service delivery for children reaches an acceptable standard in multiple services at the same time. The maps that I show that children do not receive the adequate service provision in all subdomains of service delivery in any municipality, very unfortunately. And this implies that there are children throughout the country hindered from meeting their full potential. They're not receiving nurturing care. And these maps have potential to guide government policy and private sector actors toward improving better services, which support caregivers in providing nurturing care. Thank you. I look forward to your questions and your comments.
Thank you, Grace. Thank you. You did keep to time. And you managed to summarize a very complex paper. I'll kick off with a question, and then we'll open up for other questions. I guess the important thing to say is, I think where this paper is a really important contribution to the literature, and that we often, as a sector, need reminding that early childhood development is more than just early learning, not just around the domains in the policy and the nurturing care framework, but also the levels of government where these services are provided. So I think that really is an important contribution to the literature. In that context, so if you were to, you didn't show any of your regression tables, but I'm just wondering if you had to recommend some priorities at a municipal level. You know, what you showed is you need, like, there's so many things that need to be put in place. But so how would you, either what would you recommend as priorities other than improving the quality of the early learning programs? What would they do? Or what's a framework to determine how to prioritize the services that make the biggest difference to child outcomes? Thanks.
Sure. I think I really am passionate about this point, that there are NGOs that are doing excellent work in developing programs and early learning spaces. And often I was at a symposium yesterday that was just so encouraging and fascinating to see the energy and the drive around NGOs that do early learning, sort of invest in ECD. And a few of them made comments that we were surprised that our ELOM score wasn't better or didn't show more improvement. And I think the thought that just occurred to me is that it isn't your fault. These children may have an unclean environment at home or come to the ELP hungry, and you could provide perhaps the exact same ELP or early learning program, but improve the caregiver support to help them learn and to notice if their child has had diarrhea for more than 3 days. And you could see a marked improvement in the ELP sort of scores, the ELOM scores, without really changing much about the program. And I just think this is kind of untapped potential. And I know I'm preaching to the choir, everybody knows this, but to answer your question, Colin, I think one of the indicators that stood out time in all of my models was waste removal. So neighborhoods where, and this was regardless of the wealth of the area or the municipality, was that areas where waste was removed once a week, at least once a week, children seemed to be doing better. And I think this indicates a clean environment where waste is removed out of the environment, especially if children are going outside to play where waste might be lying on the street. And the second thing that was consistently coming through in the regressions that I ran was looking at things where, so this is my interpretation, that the elements where it was supporting the caregiver to give care to the child, this was good for children. And I'll argue this just out of the literature as well, that we see where caregivers are taught how to help their children with emergent numeracy, or help their children with enjoying reading or clapping or singing, or understanding how the importance of bedtime, supporting caregivers in terms of helping them provide adequate nutrition, and not just the information, but also actually the food systems behind the adequate nutrition. Because I think a lot of parents might know, parents in underprivileged or really poverty-stricken circumstances might know what their child needs, but they're incapable of providing it because of lack of a functioning food system. But so those are my two: waste removal and caregiver support. I think are really untapped potential boosters to child outcomes.
Thanks, Grace. So I'll open it up as Senzo. You asked 3 questions. You can choose one of your 3 to ask. Are you there, Senzo?
I'm just gonna return to my summary. Sorry, Elizabeth, which page were you asking? This one.
Senzo, do you want to ask your question?
Sure. Colin, can you hear me?
Yes, perfect.
Sure. No, Grace, thank you so much. This was really exciting. I think the introduction of the index is really useful for understanding local dynamics. Really excited to see the final products of it. I guess out of the 3 questions, Grace, the one I was really curious about is on the access to health facility subdomain. I was really curious to know whether or not, in addition to the ratio between number of children in the clinic or healthcare facility, if you consider distance, for example, and that's probably making an assumption that anything greater than 5 kilometers should be considered inaccessible. It's just a question of curiosity. Yeah, thanks.
Yeah, sure. So I was limited by data in terms of being able to understand the exact distance to a clinic. I agree that it's important. Access to a clinic means that you can get there and you don't have to wait for 6 hours. I was able to control in the regressions when I was using the ELOM data. There are most clinics say if they are less than, I think, 20 kilometers from a clinic. So I was able to control for that in the individual level results. But when creating the index, I was not able to control for that. And perhaps the municipalities who do provide adequate healthcare facility access would decrease if that, especially in sort of the Northern Cape or the Free State, where there's really a sparse population. But I wasn't able to consider that, but I do think it's important.
Thanks, Grace. Next up, Claire Pierce. You want to ask your question? Okay, well, I can answer the question. When you speak of healthcare and ELP provision, is that what is provided by the municipalities or what is available in a municipality that could be provided by? Oh, sorry, Claire, you here?
Hi, sorry. So I don't know if I'm a bit confused, or if this was explained at the beginning of the presentation, and also my understanding of different spheres of government functions. So when you speak of, I guess, when you speak of the healthcare and ELP or education provision in a municipality, are you referring to what the municipalities provide or what's available that could be provided by a provincial government or private individuals. I hope that.
Yes. So in the framing of the chapter in my PhD, which I failed to frame correctly. Thank you for asking this question. It's really helpful. So in my paper, I am very careful to discuss that there are many multiple overlapping government bodies that are responsible, both departments as well as levels of government, so national, provincial, municipal. In the National Development Plan, which is sort of a really still a respected and governing document in terms of service delivery, as well as the Constitution, municipalities are labeled and called out as the level of government which is responsible for providing healthcare services. But in reality, we know that municipalities don't receive the government funds. Provinces receive funds for education and health. Municipalities are supposed to run their own service delivery in terms of sanitation and water and waste removal, but this is also sort of coordinated provincially. So here I'm not discussing, I really don't want this to be seen as me pointing a finger at a municipality and saying, bad municipality, you're failing. I'm saying governance structures are failing children in this municipality, and the answer to how to improve government structures for service delivery for children might be different in a municipality in KZN relative to a municipality in Mpumalanga or in the Western Cape. There are municipalities in all three of those provinces that are failing, but they're likely to be failing in different subdomains or for different reasons. And it's important what you have mentioned. You said, was it the services that government provides or that are available and may be provided by many actors? It's the second one. So I've literally just taken a snapshot of what the data says. So for the healthcare access, I went to the Department of Health's website, and they have a map of all of the clinics, hospitals, and MOUs and sort of services available to children on a map. And I went and I wrote a Python script, and I scraped that data off of that map, and I was able to then get the GPS coordinates of every single clinic in South Africa, and then I put it into my data set, and I said, what is the population of this municipality? How many clinics are there? And that was including government, private hospitals, public hospitals, clinics, primary healthcare facilities, So that was really, I'm not discriminating on who is providing, I'm saying what is available. So that's a long answer to say the second option to what you said, but the framing really is important. So thank you for asking the question.
Thanks so much,
great.
Grace. That's very helpful.
I'm going to ask Anthea's question because it's kind of a follow on to Claire's. Does the data consider access to private services like through private clinics or pharmacies like Dis-Chem or Clicks?
So I do consider private clinics, but not Dis-Chem and Clicks, which is actually, that would be super fascinating. I've thought actually of looking, so I think one criticism of this paper is often that it's such a broad view and that each one of these subdomains is critical, and it's true. And I've thought of sort of doing sort of healthcare services, public services, and education services separately and looking at the dynamics. But I haven't actually thought of including sort of Dis-Chem and Clicks, but those would also be very easy to get because they're on Google Maps. So you can just get the GPS coordinates and see. It would be really interesting to see if child health is in general better where there's a lot of Dis-Chems and Clicks. That would be fascinating.
Okay, then Ruth, I think Ruth, has your question been answered in the previous questions? I don't know how to ask her. I think it's the same thing. Or you can, if you want to ask something slightly different, go for it.
Hi there, can you hear me?
Yes, hi Ruth.
Hi Grace, how are you? Thanks very much for the presentation. I think it does follow on from the this question, but I was interested in the case where you have shared government mandates and how they affect one another. So, for example, if we have a province where healthcare is in a good state, but a municipality where water and sanitation are failing, did you find that there was a relationship between there, or how did they reinforce each other? I think particularly understanding the variation within municipal services, that would be helpful.
Yeah.
Thanks.
Yeah. I think I wasn't able to look at sort of the specific, I didn't. I might be able to, which would be also really fascinating to look at a place where sort of health is good but sanitation is bad. I think the immediate answer to your question, that examples of where sort of overlapping government mandates or shared government mandates sort of reinforce one another. And unfortunately, it's more the opposite, where there are shared government mandates for the same thing. So specifically for sanitation and housing. So, or rather sanitation. So the Department of Water Affairs and Sanitation and the Department of Housing and the Department of Environmental Affairs all have some kind of accountability in terms of sanitation. And I've written an entire chapter on sanitation in my PhD, which is another presentation. But the overlapping mandate in terms of multiple sort of bodies being responsible for this one thing, it's the one that's failing the most often, and where it's failing really badly. And yeah, it's actually kind of a critical. It's kind of like an undercover ESCOM situation where the maintenance hasn't been happening and the systems have been failing, and day zero is one thing, but then there's also just like bad sanitation. I don't know a fancy word for it, but just where there's pathogens in the environment because the sanitation system and the sort of wash facilities have been failing. So but the question you ask in terms of like good healthcare but poor municipal, so good provincial healthcare but poor municipal services, there are a few municipalities where I think that might be the case. And I think I'd have to maybe look at more individual level data, something like the GHS to actually look at that. But it's a really interesting question, and I think doable with the index.
I'm gonna go through some of the questions to try to save some time. Ugeshni has asked please advise if you considered the pupil to teacher ratio in the classroom and its impact on early learning.
Yes, I did. So in the so there were two places where I considered learner education ratios. So the first was in an ELP. I considered, so meeting the government requirements is to have an ELP with a child to practitioner ratio of less, or one practitioner to 20 children. So if so that was in the sort of composite index where the ELP had to meet 75% of regulations to be considered high quality. So that was the first place where I considered learner practitioner ratios. The second was in schools. So where you see the access to quality or teacher resourced primary school, the only measure was whether or not there was one teacher to 40 children or less, which is the learner educator ratio. That's sort of the maximum in the Department of Labor policy government for teachers. Yeah, I hope that answers your question.
Well, we hope so. Was there a finding in relation to that, like a result?
Just that there were lots of schools where the primary school learner education ratio is higher than one teacher to 40 children. And I know there's a lot of research around the impact of class sizes, but I think if there are any people who have been or who have been friends with teachers, I think teaching more than 40 kids is likely to exhaust you and make you less, even if it's you're having the same impact, your level of exhaustion is just, I couldn't imagine it.
I'm going to combine Daniel McLaren and Karen Ross's questions. They're about parental support programs. So Daniel's asked us, how can this be studied, or can this study be used as a basis for training, training caregivers, supporting, improving caregiving practices. And then Karen's asked whether interested that parental support programs only fall under health. Should they not also be part of access to education as well as early stimulation, especially considering that less than 50% of 4 to 5-year-olds attend ELP, and even fewer younger children attend these centers or programs?
So to answer the question from John Atmore, I believe, this could certainly be used as training. I think it would have to be, sort of the message might have to be crafted a little bit more to really stick in people's minds. But I think it's intuitively, it makes sense. Every time I've presented this to a parent, I kind of get nods like, yes, this is true. But understanding the reason why children need all these things, and that you can't substitute one for another, I think that would be excellent training material. And also to equip and empower caregivers to realize that they need support in some areas in order to be able to provide the care that the nurturing care that children need. And I think that empowering and equipping caregivers is as I mentioned to Colin, a really untapped piece of potential. And it's not that parents are bad parents, but I think helping parents understand within context and culture, and celebrating context and culture, the different elements that children need. These are not, the elements that children need are not defined by, they need X, Y, and Z food. They can have any food. It's not culturally defined. Every culture knows how to care for children. It's just educating them in terms of how to apply what we understand about child thriving. And in terms of the question regarding parent support programs, so the provision of parent support programs certainly is overarching in terms of parent support for healthcare, Road to Health booklet supporting their in terms of health, education. I think it's also support for parents in providing public services is, for me, what I'm most passionate about. I read quite a few case studies where the support for parents, especially in sort of township or informal settlement areas in South Africa, is just so lacking, that children, there's just these horrific stories of children playing on the floor and a huge accident happening, and they're burned by the paraffin stove, or they go blind because something pokes them in the eyes while they're playing in their home environment, and like the parent has to choose between cooking and taking care of their child, because they have to cook on a paraffin stove on the floor because it's the only place they can cook. And this case study specifically just really hurt my heart. But so I think parental support and parental communications is really overarching in all of the sort of subdomains. But I also think that perhaps you noticed that I didn't specifically measure parental support. So I didn't specifically measure parental support or social security, so access to grants. And this I have been caused to really think about excluding these two specific measures. And I think the thing that I'm trying to get across here is that whether or not a parent is supported and whether or not they receive a grant, they should still have access to healthcare and waste removal and high quality ELP. And that hopefully them receiving a grant will enable them to access these things. But even so, without that grant, because there are people who do not receive the grant who need it, or who don't receive, the grant isn't big enough to really help them, they should still be able to access an ELP. They should still have waste removal, and that the grant shouldn't play the role of those things. And that, so I'm trying to measure service delivery apart from social security for children. The social security is undeniably important and has been shown to have a really big impact. And I think parental support programs are similar, but independent of whether the parent is supported, they should still have access to this index of services. And I hope
Grace, we're out of time, but so I just wanted to get Vioa's question is important about whether you picked up any differences between service delivery in rural and urban municipalities with regard to health outcomes, but maybe in terms of other outcomes. That's the last question, and then you have to finish.
Last question and a very quick answer. Urban, so metro, the 8 metro municipalities definitely had the best health outcomes. I controlled for the metros, and they had a very significant positive coefficient. So yeah.
All right. So we're out of time. I thought Liesl just posted a very detailed question, Benita. I'll share these questions, and then maybe we need to figure out a way of giving you the opportunity to respond to the questions. But then also, I guess, the paper is on our website, and so everybody can read the paper. And also, I think if you're okay with people getting in touch and asking questions, then you can post your email, your email address. So thank you, everybody. Thank you, Grace, for doing the paper and for presenting the paper. I think Tobile, okay, so next month's presentation, I'm going to put the slide up, but in any case, it's a presentation by Kate Rich and a number of other authors on stunting in South Africa. It will be on, I think, the 11th of September. Yeah, the paper's entitled Measuring Stunting and Tracking Trends in Prevalence, Conceptual and Methodological Considerations Focused on South Africa. We'll be putting the paper on the website, hopefully before the next webinar, including a policy brief. And hopefully everybody can engage with the content of the paper if you have time. Otherwise, wait for the webinar on the 11th, and you can get a snapshot by Dr. Kate Rich. But thank you, everybody, for attending today, and hopefully see you on the 11th of September. Thank you, Grace, again for your work.
Thank you. It's great to engage, and I welcome emails. I've put my email in the Q&A or the chat function. Cool. Cheers. Thanks.